Hello and welcome. I'm Catherine Banwell, your host for today's program. Today we'll discuss the latest advances in non-small cell lung cancer care as part of our INSIST series, which encourages patients to play an active role and insist on better care. Before we get into the discussion, please remember that this program is not a substitute for seeking medical advice. Please refer to your healthcare team about what might be best for you. Well, let's meet our guest today. Joining me is Dr. Isabel Preeshagul. Dr. Preeshagul, it's so good to have you with us. Thank you. Would you introduce yourself?
Yes, thank you so much for having me and for the very kind introduction. My name is Isabel Preeshagul. I am a thoracic medical oncologist at Memorial Sloan Kettering Cancer Center, and it is a huge honor to be here with you today.
Well, we're so glad to have you with us. I'd like to start with a question pertaining to our series title, INSIST. Why is it essential for patients to collaborate with their providers on care treatment decisions?
So collaborating is so important, right? I always tell my patients this is not a dictatorship, right? This is a collaborative effort where I am here to guide you, but you are the captain of the ship. You are the one that needs to make all of the decisions, and I'm here to make sure that the ship goes in a smooth direction. So making sure we have open lines of communication, that the patients and their caregivers feel comfortable talking to me and my team, and also vice versa, and that we trust each other. It's so important because we are going for a marathon, right? We're not going for a sprint. This is a long-term relationship. Whether we're treating you for cure or we're treating you with palliative intent and it's treatable but not curable, we're going to be following with each other for a long time.
Lung cancer healthcare team, of course, consists of a number of different providers. Would you tell us about the various members on a team?
Sure. So there is, there are the people that do the scheduling that, that make sure that, the CAT scan is scheduled, that the MRI is done, your chemo gets scheduled, all of that. The schedulers are super important and an integral part of our team. And then we also have our office coordinators that answers the phone calls and, passes along the messages and assists with scheduling and sort of sets expectations and is the face of the practice. Then you have an office practice nurse or our oncology practice nurse who is, the doctor's right hand, making sure that the patients get proper chemotherapy, teaches, making sure that they understand about possible side effects, risks versus benefits, making sure medications are up to date, assessing symptoms. They are sort of like the front line when it comes to any patient call. They're triaging and they're escalating or de-escalating. That would be the office practice nurse. And then you have an advanced care practitioner, an APP, like you either have a nurse practitioner or a PA that's working with you, that's sometimes seeing patients independently, sometimes putting in chemotherapy orders, really serving as almost as another doctor. If for some reason there's, something that the doctor's not available to do, the doctor needs in a pinch, or my patients that are almost at long-term follow-up that are doing great, that are just kind of coasting, I will share with my NP and make sure that, they know her just as well as they know me. And sometimes there's a fellow or there's a resident or there's a med student that's part of the team as well, because, see one, do one, teach one. It's really important to teach those that are coming after you and serve as mentors and really include them in part of the team and part of the decision making. Yeah. And then you have the doctor that just kind of oversees everything.
Of course. How would you define treatment goals for people with lung cancer?
So the goal of treatment, I think, is really contingent upon someone's stage. But it's also contingent upon what's important to the patient, right? So we have patients that are, stage 1 all the way to stage, 3C that we treat with intention to cure. And patients that have stage 4 disease, it's treatable but not curable. So I am very transparent with that as long as I have the information to have that discussion. But that being said, there are some patients with stage 3 disease or stage 1 disease that don't really want treatment and want to focus on quality of life. And that's okay too. And in which case, at some point their cancer will likely progress. How quickly or when that will happen, we don't know. Could they pass from something else? It's possible, but you really need to talk about what's important to the patient because it's not always cut and dry.
As you mentioned, Dr. Preeshagul, there are several different support members on a team. What would you say to patients or even care partners who can sometimes feel like they're bothering their healthcare team with their questions and comments?
So we do get that concern a lot. And I always say, I'm here for you 24/7. And if it's not me, it's someone that's just as qualified to answer your questions no matter what. And I would rather get a phone call at 3 a.m. than get a phone call at 9 a.m. and it's, you need to go to the hospital right now, or God forbid something happened. I get a phone call from someone in the ICU that you went overnight and terrible things happened. So I want the phone calls to come through to keep you out of the hospital and keep you from going south. So call me. And I don't try to outline, contingency plans or criteria of what would warrant a call, because then you end up getting in trouble. I always just tell my patient, think about how you're feeling now in front of me. If you're feeling any different than how you feel at this very moment, call me.
Good advice. I'd like to turn to the clinical side of non-small cell lung cancer. What tests help you identify the type and stage of lung cancer?
So we need, obviously you need a CAT scan. You need a CAT scan of the chest, abdomen, pelvis, and you need an MRI brain and a PET scan. Those are really the gold standards for determining clinical staging. In regards to pathologic staging, it's really important to have tissue sampling. So you biopsy a site of disease that's concerning to you. If it looks like there's only disease in the chest, you want to biopsy the site where there's the tumor. And then you talk with your thoracic surgery or pulmonary team to determine the best way to sample the mediastinum for full staging.
Why is an accurate diagnosis so important?
So an accurate diagnosis is so important because lung cancer is by no means black and white anymore. There are so many different histologic subtypes that we are learning about. There are so many different molecular drivers that we are learning about. So, making sure you have the right diagnosis, full next generation sequencing testing, all of the imaging that you need could really, make or break your treatment plan.
Dr. Preeshagul, let's talk about biomarker testing. How is biomarker testing for lung cancer different from hereditary genetic testing?
So we do hereditary genetic testing for lung cancer patients as well. So I think let's backtrack a little bit. When you're doing testing on a patient, there's germline mutations and there's somatic mutations. And germline mutations are mutations that you might get from mom and dad, that they got from their parents, and so on and so forth, that you could give to your children or your brother and sister or whatever. So that's germline testing that could be passed along. That would be like BRCA or any other APC gene. But we are learning more and more that there are mutations in lung cancer that do have a hereditary aspect to them. So we are learning now that while we do somatic testing, which is somatic mutation testing, which is to find a mutation that just spontaneously happened in your tumor all on its own, it's really important to pair that with germline testing to make sure that there isn't some kind of heritable mutation that's also driving this lung cancer.
You mentioned hereditary genetic testing. Should family members of people with lung cancer undergo genetic testing then, just to be reassured?
So if there is a germline mutation, then the family members should be referred to a geneticist to have that discussion.
What are common lung cancer biomarkers?
So we have 9 biomarkers with an approval right now, but there are so many. There's more than I could even talk about today. But I mean, some of the more common ones are EGFR, ALK, ROS1, MET exon 14, you have KRAS, KRAS G12C, which is a newer one. We have NTRK, we have RET. I mean, the list goes on. HER2. I could talk for, there's not enough time on this Zoom video to talk about all of the mutations, but there's nine mutations with approvals as of now. To date, this very moment, that could change tomorrow.
Of course it could. How do biomarkers in lung cancer affect treatment options for lung cancer patients?
So it used to only be in stage 4, but now we are learning that biomarker testing is really important from the get-go because we have induction or neoadjuvant protocols that are looking at giving targeted therapy before patients go to surgery. We know that there's FDA approval for patients to get targeted therapy after surgery, and there's a survival advantage there. So Make sure that you have next generation sequencing testing regardless of your stage.
Okay, that's good advice. So we've heard how testing and a patient's individual disease can lead to more targeted options. And you just mentioned targeted therapies. How do they work?
So there's many different targeted therapies that we have. Some are given as an infusion. For HER2, for example, we have TDXD and we have TDM1. TDXD is the only drug that's FDA approved in this setting. There are clinical trials looking at TDM1. For EGFR exon 20, we have another infusional drug called amivantamab. For EGFR exon 19 and exon 21, we have a pill called osimertinib. For KRAS, there's a pill. For most of the driver alterations, it's a pill, but some of them it does require infusional therapy. But these are therapies that are targeted at the cells that harbor that mutation.
Let's turn to immunotherapy. What is it and how does it work?
So immunotherapy is basically teaching your body to recognize cancer as foreign. So when you have, I always kind of use this hand model. So basically a normal cell has, let's say, 3 prongs. And then sometimes what happens is cancer will grow a marker called PD-L1 that makes it hide from the immune system. So the body thinks that this is a normal cell. So what immunotherapy does is it comes and it sort of puts a cap on that PD-L1 so that the cell looks foreign again and the body can attack that cell and get rid of it. So it's almost like ramping up your immune system to recognize that marker and get rid of that cell.
What is the regimen for immunotherapy and how often is treatment administered?
So immunotherapy is approved in, the neoadjuvant setting, which means before chemotherapy, it's approved after chemotherapy, and it's approved in the stage 4 setting. There's many different regimens and many different dosings and many different drugs, but it's typically given in your veins either once every 3 weeks or once every 4 weeks for a certain amount of time. If it's given in the curative setting and it's given indefinitely or until there's disease progression or intolerance in the stage 4 setting.
Okay. Let's touch upon the side effects of these types of treatment. You've mentioned that there are so many, but what are some of the major side effects and how are they managed?
Side effects of immunotherapy can include pneumonitis, which is inflammation of the lungs, any kind of endocrinopathy, like issues with your thyroid, issues with your pancreas, like diabetes. It can cause colitis, which is diarrhea, inflammation of the colon, hepatitis, inflammation of the liver. It can cause cerebritis, inflammation of the brain. It can cause arthritis or arthralgias, inflammation of the bones, and it can also cause rash and fatigue. Typically, if it's the thyroid, it's managed with thyroid replacement hormone or a drug that would calm down the thyroid if it's overactive. Pneumonitis is steroids. Hepatitis is sometimes treated with steroids. Colitis, steroids typically. Steroids usually come somewhere in there. Usually not with the endocrinopathies, but the other itises, it's typically we start with steroids and go up from there. And the goal is to really recognize these toxicities before they become a problem and just at the glimmer of them just starting.
So would you consider these treatments to be personalized medicine then?
So it's personalized in the sense that if someone has a high PD-L1 expression, there may be some data to demonstrate that they may benefit from immunotherapy or have a response. If someone can't tolerate chemotherapy, or is not interested in chemotherapy or has other reasons that may preclude them from getting it, it might be reasonable. So in that sense, it is considered personalized.
How would you define personalized medicine?
To me, personalized medicine takes into account, the biologic makeup of a patient's disease, like if they have a mutation, what their PD-L1 status is, what the histologic makeup of it, what's their stage, and then on the other hand, what's important to that patient. If they're a tailor, you want to make sure you're not giving them a medication that's going to cause neuropathy so they can't use their hands. If they're, they enjoy playing the harp or the piano, same thing. If their goal is to continue to run marathons, you may want to avoid something that's going to cause inflammation of the lungs and risk them for pneumonitis. Tailoring to make sure that the treatment is part of their life, but does not become their life.
Yeah. If the test results don't reveal one of the biomarkers you've been talking about, what other treatments are available?
So if I don't have an FDA approval, then sometimes we look to see if there is a clinical trial in our early phase development, drug development program, and we talk about a clinical trial. If there's no clinical trial and I don't have an FDA approval, then we have to talk about what options are considered standard of care and how to make that work into the patient's lifestyle.
What about surgery? When is it used?
Surgery is typically used in the curative setting with early stage disease. We're really trying to give patients some kind of chemotherapy or some kind of treatment before they go to surgery. It's shown to improve outcomes. It just gives us a in vivo view of how the tumor will respond to the treatment. So we typically use surgery in the curative setting, and at times it's appropriate to use surgery for a metastectomy when you have one little site that's growing. Sometimes after a tumor board discussion, it might be reasonable to resect that area.
Is radiation still used?
Same thing, it can be used in the curative setting, typically for patients with stage 3B or stage 3C disease, and combined with chemotherapy, patients that are not considered surgical candidates, or it's used in the palliative setting when patients have painful metastases.
Would you define the B and C? You've mentioned that a couple of times.
Yep.
We're used to hearing stage 1, 2, 3, 4. But
yeah.
What's a stage 3B and a stage 3C?
Sure. So it does get a little bit into the weeds here about the size of the tumor and the amount of lymph nodes and location of the lymph nodes. But basically, stage 3A is considered resectable. That means that could be like the size of the tumor with no lymph nodes, or it could be a smaller tumor with a lymph node on the same side as the disease. Stage 3B would be a lymph node right underneath the windpipe at the station 7. And stage 3B also includes lymph nodes that have crossed over to the contralateral side. And stage 3C would be lymph nodes that are maybe up at the contralateral supraclavicular space.
Okay. Do treatment options change if the lung cancer returns?
Yes, they do change depending on, if this is the same tumor same tumor type that's come back. It's typically a different treatment algorithm. Yeah.
Okay. And should biomarker testing be done again if a relapse occurs?
100%. Because it guides everything about a patient's treatment. It's super important.
Okay. What are you excited about right now in lung cancer research?
I am excited and overwhelmed by the fact that we have so many approvals and so much exciting data that was just presented at ASCO and World Lung and ESMO that it's next to impossible to keep up. And I'm happy that we have that problem. And I'm happy that the patients have, there's a spotlight on lung cancer when we were in the shadows. And now I think we have the spotlight, and all of these approvals, with it being Lung Cancer Awareness Month as well, I think is just so important, just to make sure that we get the knowledge of these new approvals out there, though that is another struggle.
Well, are there any current clinical trials that look promising to you?
I think there are many clinical trials in the induction setting. There was some data that was just presented on Alina looking at adjuvant alectinib. We just had we have approval for adjuvant osimertinib on the ADORA trial. But we are learning more and more that as these targeted therapies have approval in stage 4, we're trialing them in stage 3, and then we're going to trial them in earlier stages and earlier settings. So this has been the pattern of how drugs get approved. So yes, there's lots of exciting data coming through.
That's excellent. Can you talk about antibody drug conjugates and where they fit into lung cancer care?
Yeah, that's a great question. I don't think anyone knows the answer as to where they fit in just yet. We have probably over 300 antibody drug conjugates that are in development right now. And one of the more common ones that we use is trastuzumab deruxtecan, or TDXD, which is used in patients that harbor HER2 alterations in the stage 4 lung cancer setting. It is basically almost like a Trojan horse. So you have this antibody, it's typically IgG1 immunoglobulin, and then you have a linker, And then at the end of that linker is the warhead or the chemotherapy agent. So the antibody comes in towards the cancer cell looking very innocent. It binds to the cancer cell. And once it binds, then everyone inside the Trojan horse or this warhead rush into the cell and get to do its damage. So it's a totally different mechanism. We're trying to outsmart some of the bypass mechanisms that that cancer cells develop. And this may be the new wave, but stay tuned, more to come.
Right. So it's promising. How can patients find out more about current clinical trials?
So you can always ask your healthcare practitioner if there are any clinical trials at the institution that you're at, but clinicaltrials.gov has all the clinical trials that are available, nationally and internationally. You just type in your disease type, you can type in a couple keywords, EGFR maybe, or ROS1, or, stage 4, something along those lines, and then it should populate a list of clinical trials and what institutions have them open, if they're still accruing or if they're not, and a contact on that trial.
If a patient is interested in a clinical trial, what kinds of questions should they be asking their healthcare team about the trial?
So the first question to ask is, do we have any clinical trials that are appropriate for me? If the answer is yes, are they appropriate for me now, or are they appropriate for me if what I'm on right now is not working? So trying to figure out where that will be. And if they are appropriate for you now, how can I get evaluated, and how can we get things underway?
Yeah. What would you say to patients who are interested in participating in a clinical trial, but they're nervous about it?
I think one thing that I love about being on a clinical trial is that there are more eyes on you. Because we are looking to get something approved and we are just watching every single little granular detail, in a way, it's almost like you're being more micromanaged than if you were on standard of care, because of just how many stop and checks there are, how many eyes are looking at your labs after the doctor and the nurse practitioner and the fellow take a look at everything. It's 10 other people. So it's almost like it's extra safe because of all of that. It's exciting because you are hopefully getting tomorrow's treatment today, right? You're trailblazing the way for other people after you. So I think it's exciting, but of course it's nerve-wracking. It's something new. You don't know if it's going to work. But I have to believe that the way that clinical trials are designed now, and the clinical trials that we choose to open here, we really hope are going to be pushing the space forward.
Yeah. I'd like to get to a few questions that we received from audience members prior to the program. How do you help a family member that is an overwhelmed caregiver but refuses help? Any tips on how to provide support to this person?
I mean, I think we see caregiver burnout thousands of times a day, unfortunately. And the first thing is knowing how to recognize it. And the second most important thing is taking the time away from the visit with the patient to address the burnt out caregiver, because there is not enough time in any visit there's never enough time in my mind to spend with a patient. I'm always, pulled in 1,000 different directions. And I think we all feel that. But taking the appropriate time to sit down and to say, hey, listen, I recognize that you're burnt out. I can see it. Who is in your corner helping you? And just directing focus away from the patient just for a moment, and to really focus on that caregiver, and to rely on the social work team and the case manager and the support groups that your institution may have, and to make sure that they know about those resources.
Here's another question we received. Can you share more information regarding treatments available for stage 4 lung cancer and their side effects?
It depends on if this is non-small cell or small cell. It depends on if you have a driver alteration or not. So I think that is, a little bit challenging to talk about, in just one session. But basically, I mean, you're probably looking at some kind of targeted therapy if you have a mutation, versus standard of care if you don't have a targetable mutation, versus a clinical trial. And I think those are kind of like the big baskets.
When is a second opinion necessary?
A second opinion is necessary anytime you want a second opinion. There is no right or wrong time. Anytime. You're just not jiving with your oncologist after the first day you met them, second opinion. You're at the end of the line and you really want to know more, second opinion. You've met 2 other doctors, you're not jiving, third opinion. It's always appropriate. Anytime you want.
So the patient shouldn't feel obligated to stay with that one provider.
Never, 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 never. No. Please don't feel that way. There are no hard feelings. And if there are, that's not the right oncologist for you. It needs to feel like a perfect friendship. And if it's not that, it's not the right fit.
Before we close, Dr. Preeshagul, I'd like to get your final thoughts. What would you say to the audience about the future of lung cancer care and treatment?
I do think that the future is bright because, as I had mentioned, there is now this light that is shining in the lung cancer space, and things are getting approved and discoveries are getting made faster than we can even keep up, which is exciting and overwhelming and daunting. But I am happy that finally this space is taking off. So I feel optimistic.
All right. Well, I want to thank you so much for taking the time to join us today, Dr. Preeshagul.
Thank you so much for having me. These were wonderful questions, and I look forward to many more discussions with you. Thank you.
And thank you to all of our partners. To learn more about lung cancer and to access tools to help you become a proactive patient, visit powerfulpatients.org. I'm Catherine Banwell. Thanks for being with us today.